Very good evening to everyone. So today we are back with our journal club session. So we are again doing something different this time. So we are trying to see, interesting case reports and images in pediatric neurology in say around last 6 months, maybe 1 or 2 months here and there, which would be a review of, Indian and world literature. Last time we did all the, original articles and important reviews that have come out. So this time we are doing all the interesting cases and images that has come out in last, maybe 7-8 months. So the team today is from Government Medical College, Thiruvananthapuram. And the moderator is, we all know her, is Dr. Mini Sridharan. She's Professor, Department of Pediatric Neurology at Government Medical College, Thiruvananthapuram. So without delaying any further, I'll hand over the proceedings to Dr. Mini. Over to you, ma'am.
Thank you, Dr. Vishnu, and good evening, everybody. And thanks to AOCN for providing opportunity for my residents to present today. And today, my second year DM residents, Dr. Anju Ennachurian and Dr. Asmi Habib will be presenting some interesting case reports and videos. And over to you, Anju, for starting your presentation. As you all know, the case reports are very important when we start managing individual cases, when we have a dilemma in diagnosing as well as managing cases. So we'll just go through the interesting case reports over the last 6 months. Over to you, Anju.
Hope my screen is visible.
Yes.
Good evening, everyone. I am Dr. Anju Charian, a second year DM resident in Pediatric Neurology at Government Medical College, Thiruvananthapuram. So the first case report today is a case of faciobrachial dystonic seizures as a sign of relapse in a child with LGI1 encephalitis. So it is authored by Alotaibi, Shahid Bashir and Ali Mir from King Fahd Specialist Hospital, Saudi Arabia, and it was published in Child Neurology Open in May 2022. So as we know, the autoimmune encephalitis can be associated with intracellular as well as extracellular antigens. And the common antibodies which are associated with autoimmune encephalitis are extracellular, whereas those resulting in paraneoplastic syndromes such as anti-O, anti-WHO, anti-GAT65, etc. are predominantly intracellular. So among the autoimmune encephalitis, LGI1 NMDAR is most commonly seen in the pediatric population, whereas LGI1, Caspar2, GABA-B, etc. are seen among the elderly. So LGI1 is most commonly seen in elderly with a median age of around 64, and it presents with frequent focal seizures. One characteristic seizure which is described in LGI1 encephalitis is faciobrachial dystonic seizure. And the other features that are associated includes amnesia and serum hyponatremia. It is only very rarely described in children. So here, LGI1 encephalitis, that is leucine-rich glioma inactivated protein 1, is associated with voltage-gated potassium channel complex. It's IgG4 antibody mediated, more commonly seen in elderly with a median age of 64 years and presence with focal seizures. These seizures are resistant to anti-seizure medications but can respond very well to immunotherapy. And MRI will usually show medial temporal lobe features, signal abnormalities. So in this case report, they mentioned a girl child, 7-year-old, who presented with sudden awakening from sleep, being frightened and making whooping sounds. This was followed by tonic flexion of upper extremity with eye and mouth deviated to one side. So EEG was taken. It showed central temporal spikes, and she was diagnosed as epilepsy with centrotemporal spikes. But she continued to have frequent seizures, ultimately requiring pharmacological coma and multiple anti-seizure medications. Because of recurrent pharmacoresistant seizures, immunotherapy, including methylprednisolone pulse and IVIG was tried. And at the same time, CSF was sent for LGI1 IgG CSF was sent for autoimmune encephalitis workup, which showed LGI1 IgG antibody positivity. MRI was done, which showed diffuse supratentorial brain volume loss with a PET scan showing subtle hypometabolism in the right temporal and bilateral parietal regions. CT screening was done to rule out paraneoplastic syndromes, and there was no malignancy found. And she had a good response to this immunotherapy. There was a reduction in seizure frequency and her cognition improved. Steroids were tapered over 6 months and she was maintained on monthly IVIG. She remained relatively seizure-free for 5 months, following which she had a relapse with exacerbation of seizures. Again, a retrial of IV methylprednisolone and IVIG was given, and the seizures responded with ceasing within 2 days. And for the next 7 months, she remained seizure-free with a return to neurocognitive baseline. Her steroids were tapered and stopped. And at 7 months, after 7 months of seizure freedom, she had a relapse. And this time, the seizures were frequent faciobrachial dystonic seizures occurring up to 100 episodes per day. These were characterized by a dystonic posturing of right arm and face, maybe with or without urinary incontinence and incomprehensive speech and confusion. Again, 2 trials of IVIG redosing was done with no significant response. She continued to have frequent seizures. A CSF LGI1 IgG antibody levels were repeated and was found to be positive. Let me just go to. We can see the characteristic seizure here with dystonic posturing of a right upper limb and face. So in the corresponding EEG, again, we can see a high voltage activity with attenuation of activity later on, followed by a fast activity. She'll also sometimes have abnormal vocalizations following this episode. So this was a characteristic faciobrachial dystonic seizures. Now, since IVIG and methylprednisolone was previously tried, rituximab was given. Rituximab, they've mentioned the dose is 435 milligram per meter squared, and 4 doses were given once weekly, and she became seizure-free after the 4th dose. There was improvement in EEG, and according to the mother, she had normal attention, memory, and concentration, and she has remained seizure-free at follow-up, that is 1 year, 9 months into follow-up. The anti-seizure medications were also tapered. So LGI1 and Caspar-2 autoimmunity in children. In previous systematic literature review, there are only very few cases of LGI1 Caspar-2 reported among children. In this systematic literature review, 37 cases of LGI1 Caspar-2 positivity has been noted in children, out of which only 10 has presented with encephalitis-like features. And none of these 10 had any faciobrachial dystonic seizures or hyponatremia. These are predominantly seen in the elderly, and there are very few case reports in children. This is a very large series of around 13,319 pediatric patients who underwent serological evaluation for neurological autoimmunity. So out of this 13,000 around patients, only 264 were positive for VGKC. And then on later analysis by cell-based assay, only 13 of them were positive for either LGI1 or Caspar-2. So as we can see, it's extremely rare in children. And among these 13, encephalopathy was the commonest presentation, and no faciobrachial dystonic seizures were identified. So LGI1 encephalitis is very rare in children, but it may present with the features as seen in elderly, such as faciobrachial dystonic seizures, and it will respond very well to immunotherapy, particularly rituximab, and it can improve recovery and the prognosis. Coming to the next case report. So this childhood vasculitis syndrome mimicking GBS, authored by Pradeep Kumar Jena, Swastika B.
Just a minute, just to summarize that case, we will do the summary after each case. So this case actually is a classical presentation of limbic encephalitis, where there is a faciobrachial dystonia as well as memory decline and encephalitis-like feature with a temporal lobe involvement, which is classical for an adult but uncommon in children. And the other types of common autoimmune encephalitis we come across is, as we all know, NMD encephalitis and Moog-associated encephalitis. And then The one which presents with the anti-seizures is anti-GABA-A receptor encephalitis, which will be associated with a lot of cortical and subcortical MRI signal changes. So this is a very classical presentation of LGI1, which Dr. Anju has presented. You can continue with your presentation now.
So the second case report is a childhood vasculitis syndrome mimicking Guillain-Barré syndrome. So authored by Pradeep Kumar Jena, Swastik Abhi Satpathy, Sarthak Naik, and Alok Satyaprakash Naik from SLN Medical College and Hospital, Odisha. This was published in Indian Pediatrics Case Reports in August 2022. So the case is a 12-year-old girl who initially presented with fever, pain in both legs, and diffuse abdominal pain, following which she developed gradually progressive weakness of both lower limbs around 2 days after fever onset. And this progressive weakness had progressed for around 12 days. It started off with a distal weakness. She initially had difficulty in wearing her she had slipping of her chappals, and later on progressed to proximal weakness. She had difficulty in climbing stairs and climbing onto bed. But she had no upper limb or trunk weakness. She could very well maintain a sitting position in bed. There is no history suggestive of any cranial nerve palsies, no respiratory muscle weakness, bowel or bladder symptoms, no seizures or altered sensory. So from the history, here is an acute onset, slowly progressive, ascending type of symmetrical weakness. From history, it's a symmetrical weakness of both lower limbs. And in her initial clinical examination, her vitals were stable, sensorium was normal. There was no systemic manifestations such as rashes, skin lesions, nodules, ulcers, or joint involvement. In nervous system examination, the prominent features were hypotonia and diminished power in all limbs, with lower limbs more predominantly affected. It was symmetric weakness, and there was generalized hyporeflexia also. The sensory system acute ascending paraparesis. The first diagnosis considered was Guillain-Barré syndrome, and then in the setting of the COVID pandemic, MISC was also considered, and viral myositis, even though it is ascending progressive weakness, they've considered viral myositis also as a probable differential diagnosis. In the investigations, microcytic anemia and neutrophilic leukocytosis with normal platelet counts. The creatine kinase was mildly elevated. LFT, RFT was normal, and CSF study was also normal. The NCS showed motor demyelinating polyneuropathy. Among inflammatory markers, the acute phase reactants, ESR and CRP was elevated. The other markers of inflammation, such as serum ferritin, fibrinogen, etc., was negative, hence ruling out MISC. As the illness progressed, at around day 5, she developed a respiratory distress with tachypnea and desaturation. Chest X-ray showed non-homogeneous patchy infiltrate in right lower lobe. She also developed hypertension. It was noted first on after day 5 of illness, and because of the diffuse abdominal pain, ultrasound was done. She had hepatomegaly clinically, and on ultrasound, she had an ill-defined hypoechoic lesion in left liver lobe. And then CECT abdomen was done, which showed infarct in the caudate lobe, along with pneumobilia pneumatosis intestinalis. The CECT abdomen also showed acute cortical necrosis in kidney. After 2 days, she developed skin lesions, reddish maculopapular lesions and purpura over palms and soles, and later went on to develop gangrene of left index finger. So here, she continued to have persistent fever throughout these course. So here is a case, persistent fever with inflammatory demyelinating polyneuropathy, vasculitic phenomena in the form of multiple multiple infarcts, hypertension, skin lesions, and gangrene, elevated acute phase reactants, ESR and CRP, suggestive of vasculitic process, underlying vasculitic process, probably small vessel and medium sized. So the CECT showed pneumobilia. There was purpura on palms and soles and dry gangrene of index finger. In further investigations, anti-SSB antibodies were positive, ANCA was negative, and hepatitis viral markers were negative. So anti-SSB can be positive in SLE and Sjogren also, but the clinical, it did not fulfill the clinical criteria. But for polyarteritis nodosa, she had 1 out of 2 major, that is, renal involvement was there in the form of acute cortical necrosis of kidney, and 6 out of 10 minor cutaneous findings, GI system involvement, peripheral neuropathy, hypertension, lung involvement, and acute phase reactants were positive. She was clinically diagnosed as a case of polyarteritis nodosa. She was given IV methylprednisolone followed by oral prednisolone. It is not clear whether IVIG was given at the onset, as she was diagnosed as AIDP at the onset. So she was later given IV methylprednisolone, and monthly cyclophosphamide cycles for around 6 months were planned. So here, neuropathy may be a heralding feature in up to 25% of patients with polyarteritis nodosa or ANCA-associated vasculitis. And many of them may have an acute presentation like this one. 1/3 can have a chronic indolent course. The most commonly affected part is peripheral nerves, followed by anterior horn cells and sensory or autonomic ganglia. Mononeuritis multiplex is the signature phenotype, but the other phenotypes such as asymmetric polyneuropathy and distal symmetric polyneuropathy, as we have seen in this case, may also occur. Cranial neuropathies are rare and occur in less than 10% of patients. So acute symmetric demyelinating polyneuropathy, our first diagnosis would be GBS, but in the setting of other systemic manifestations, then a childhood vasculitis syndrome should be kept in mind. Hypertension may be attributed to the dysautonomia in GBS, but again, vasculitis syndrome should also be kept in mind.
Okay, Anju. So that was a case of vasculitis, which initially presented as neurological manifestation, as peripheral, as GBS, rather than the usual mononeuritis multiplex that we come across and the painful peripheral neuropathy. Rather than that, this is presented as a GBS, and there has been previously also some few case reports in adults with vasculitis presenting with GBS-like presentation in the cryoglobulinemia as well as SLE patients. In this patient, they have mentioned clinical features were suggestive of polyarteritis nodosa-like picture. And usually polyarteritis nodosa is usually seen in older age group, around 40 to 60 years. And often there can be associated hepatitis B virus antigen also positivity. And in children, when this comes as an early presentation, one of the things which one will have to consider is a monogenic deficiency of adenosine deaminase 2 related mutation, that is DADAM2 mutation, which can also present with a polyarteritis nodosa like phenotype with cutaneous vasculitis and vasculitis affecting internal organs as well as central nervous system and peripheral nervous system manifestation. But the authors in this case report have not mentioned whether they have investigated for this particular entity. And again, the treatment wise, if the polyarteritis nodosa is associated with hepatitis B, one should be using antiviral agents and plasma exchange instead of the initial cyclophosphamide and steroids which they have used. And in case of DADA2, of course, steroids and then tumor necrosis factor inhibitors. And if there is a severe bone marrow involvement, then stem cell therapy is one. Hematopoietic stem cell therapy is also the additional therapy which has been mentioned. And before we move, so that is a learning point in this case, that there can be very rare presentations of vasculitis like GBS also. And if the patient, we have to keep the patient under follow-up even after the patient recovers from the initial neurological manifestations to see whether there is any additional features coming up. And there was a question from Dr. Kaushik regarding the initial first case, as is there any asymmetry on EEG in faciobrachial dystonia, and how common is asymmetric clinical features in autoimmunity? I remember, Dr. Anju, you told that this patient was misdiagnosed as a case of
Centrotemporal
epilepsy, but they haven't mentioned whether there was a centrotemporal spikes. But then the EEG which you showed projected, it was like a generalized IEDs and a burst of generalized IEDs which I could see, followed by some myogenic artifacts also. But classically, the child has presented with a faciobrachial dystonic seizures. And in even in autoimmune encephalitis due to NMDA encephalitis, there are patients who can present with seizures as an initial manifestation, and they may present with a focal seizures also. And we have also come across patients who manifest with focal symptoms like a dystonia or chorea-like manifestations in our own institute. So focal manifestations can occur even though it is an antibody mediated. And in a study which was published by Dr. Vinayan, out of his 28 patients, I don't know the percentage, but out of his 28 patients, he has mentioned that 6 of them presented with the initial manifestation of focal seizures, and 5 of them were girls and 1 was a boy. And they had a focal IEDs also. And initially the diagnosis was as a focal seizure. And in also LGI1 antibody mediated encephalitis reported in children, instead of this faciobrachial dystonic seizures, their initial manifestation in the other case reports was focal seizures only. And this is so particular. What is so particular about this case was a faciobrachial dystonic seizure as the first case report from pediatric age group. Okay, you can continue with the third case.
The third case report is of 3 Indian siblings affected with progressive myoclonic epilepsy due to unwourished Lundborg disease. The authors are Kavita Srivastava, Beena Thakur, Shuvendu Roy, Surekha Rajatyaksha, Chaitanya Datar from Bharati Vidyapith University Medical College, Pune, and it was published in Indian Pediatric Case Reports in 2022. So the index case is a 17-year-old girl. She presented with generalized tonic-clonic seizure since 10 years of age, which occurred every 2 to 3 months, and she was on multiple anti-seizure medications but continued to have GTCS. At around 2 years into onset of the illness, she started having brief jerky movements of arms and legs on attempted movement, that is action myoclonus, and this worsened when she tried to get up from sitting position or tried to climb onto the bed. It worsened. It also worsened with stimulus like bright light or loud sound. Also, she had myoclonus. The characteristic feature was that she had a waxing and waning course. She had periods where she had a relative seizure freedom, followed by periods where she had worsening of seizures as well as myoclonus. And around the same period, she also developed ataxia and tremors. A mild cognitive decline was noted, no significant memory loss, mild cognitive decline, which the parents attributed to the multiple anti-seizure medications. She had no other manifestations such as dysphagia, dysarthria, visual impairment, or visual hallucinations. No cardiological or hematological involvement was also there. So clinical examination, predominantly extrapyramidal features like mask-like facies, action myoclonus, bradykinesia was there, and ataxia and tremorlessness. Fundus was normal. There was no cherry red spot, retinitis pigmentosa, or optic atrophy, and she had no oculomotor apraxia. Motor system examination was normal. She was born out of a third-degree consanguineous marriage, and interestingly, 2 of her younger siblings, a girl and a boy, also had a similar presentation. So the younger sister, currently 13 years of age, had onset of GTCS from 11 years of age. She also had severe action myoclonus, ataxia, tremors, and bradykinesia, and mild cognitive decline was also there. So her picture is very similar to the elder sister, and both of them had to drop out of school because of the severe myoclonus and cognitive decline. The younger brother is 11 years, and he had the onset of illness only recently. He had 1 episode of GTCS, after which he had a relative seizure freedom, following which he has again started having GTCS. His other symptoms are minor when compared to his elder siblings. He has mild action myoclonus with no ataxia or tremors, and his cognition is well preserved, and he goes to school. He's on levetiracetam and clonazepam. So here the EEG, as we can see, it shows multifocal and generalized spike and polyspike wave discharges. It also shows a photoparoxysmal response. So when we consider an epilepsy syndrome with GTCS and myoclonus at this age onset, that is in adolescent age group, one of the first things that comes to our mind is juvenile myoclonic epilepsy. But with this additional feature such as ataxia and tremors, we also have to consider progressive myoclonic epilepsy syndromes. But unlike other progressive myoclonic epilepsy phenotypes, such as NCL or Lafora body disease, here these children did not have any progressive neurological deterioration. They had mild cognitive decline, and characteristically, they had alternating seizure-free periods and periods with refractory seizures. So this is highly suggestive of epilepsy, progressive myoclonic epilepsy type 1, that is Unverricht-Lundberg disease. MRI brain was done for the two elder siblings, which if both of whose MRI was normal. MRI is pending for the youngest child. There is no other neuraxial involvement suggestive of like visual optic atrophy as in NCL, or visual hallucinations as in Lafora body disease. Then no oculomotor apraxia, which may be suggestive of Gaucher's disease. No organomegaly that can be seen in sialidosis. Fundus was normal. And so our predominant, so first TD here would be progressive myoclonic epilepsy, like Unverricht-Lundberg, which has features of both a genetic generalized epilepsy, because there is no significant neurological deterioration, as well as features of a progressive myoclonic epilepsy phenotype, such as ataxia and tremors. So genetic testing, the mutations in cystatin B gene localized to chromosome 21 Q22.3. So it's the mutation is an unstable dodecamer repeats. Like more than 30 repeats is pathogenic. The fact is that these dodecamer repeats may be missed if we do an exome sequencing. Hence, it's very important to do a southern blot or PCR testing. So PCR testing was done for these siblings, and they were found to have the dodecamer repeats, and their parents were also heterozygous carriers. So when there's generalized seizures with onset in adolescence with myoclonic as well as GTCS, in addition to a genetic generalized epilepsy syndrome such as JME, other possibilities such as an Unverricht-Lundberg and progressive myoclonic epilepsy should also be considered in the presence of mild cognitive decline and extrapyramidal features.
And there are, Dr. Sridhar has raised one question, like what are the clinical clues to differentiate between progressive myoclonic epilepsy and JME at onset? Because both of them have GTCS and myoclonus at onset. So how would you differentiate both?
Both will have GTCS and myoclonus on awakening. In addition to that, other features like cognitive decline and ataxia and tremulousness can suggest Unverricht-Lundberg. The other progressive myoclonic epilepsy phenotypes will have more.
These people have more of a, as Dr. Kavita has described, action myoclonus.
Like action
myoclonus when they try to do things. And second thing is, again, when you can continue. What are the other differentiating features?
Like in case of neuronal ceroid lipofuscinosis, it can present with visual loss and optic atrophy on fundus examination. Then in Lafora body disease, the child can have visual hallucinations, and all of these are rapidly progressive. Unverricht-Lundberg has a relatively stable course, and these seizures and myoclonus may actually like stabilize and remit after around 5 to 10 years. The other DDs could be Gaucher's disease, sialidosis, other PME phenotypes, but all of them will have other associated neurological manifestations. And systemic manifestations such as organomegaly may be seen in sialidosis.
Okay, one thing which you have to remember, Dr. Joshi, Sridhar, is that the classical presentation of a JME phenotype is the early onset. Whenever there is a sleep deprivation, when children get up from sleep quite early in the morning, that is the time when they have usually symmetric myoclonus involving the upper limbs. They start with that, and after a few days, maybe immediately after that symmetric myoclonus of the upper limb, they going to develop GTCS. That is a classic presentation. And often, if you look at their EEGs, they have phantom absences. Often the phantom absences are missed. Phantom absences means they are not picked up clinically, but when you do an EEG, video EEG, you may pick up absences which last for only less than 10 seconds, so that they are not clinically evident for the most of the person. So such phantom absences can also be recorded during EEG for JME patients. So JME patients classically have a normal EEG background, and 20 to 30% of them can have a photoparoxysmal response. And the photoparoxysmal response is in the same range as in Lafora body disease, starting somewhere around 16 hertz till 24 hertz or so, maximum around 18 hertz. So the same is for Lafora body. In Lafora body disease, you get occipital IEDs initially and visual hallucinations, and the seizures and the clinical syndrome rapidly deteriorates. Whereas in case of this Unverricht-Lundberg, the initial presentation, you may confuse with Jamie, but the most important thing is that in Unverricht-Lundberg, the EEG may show some slowing and the action myoclonus is also there. And most important is the JME usually very well responds to very small doses of valproic acid or levetiracetam, whereas in the other cases, you may not get that good response to your usual anti-seizure medication. So I think anybody who wants to add on to that can comment on this. And
waxing and waning courses also characteristic.
Again, that is classically in JME, the usual precipitating factors are sleep deprivation if they skip the medication, and in adolescents, especially if they have, if they take alcohol, these are the precipitating factors. Otherwise, it is a very well controlled epilepsy syndrome. And second thing was about the first case. Somebody has mentioned that fever at the onset is a red flag not to consider the diagnosis of a GBS. That is the comment which I've made. Is GBS usually a fever at onset is not a classical manifestation. But I think for this patient, they presented initially with a painful peripheral neuropathy, painful ascending type of neuropathy, and later only the child had fever and other manifestations. That's what I remember. Okay. Okay, Anju, thanks for that. We can stop sharing the screen now and we'll go on to the next discussion by Asmi. Asmi, you can start presenting now.
Is my screen visible?
Yes.
Good. Good evening, everyone. My first case report will be the initial presentation of PCDH19 related epilepsy with new onset refractory status epilepticus and treatment with anakinra. It was published in the Green Journal of Neurology in August 2nd, 2022 by Robin T. Varghese, Shefali Karkare, Annapurna Poduri, and Sanjeevi Kothari. They are based from Department of Pediatrics at Cohen Children's Medical Center, New Hyde Park, New York, and Department of Neurology, Boston Children's Hospital, and Harvard Medical School, Boston. So the case report is of a 7-month-old girl who had no previous significant antecedent medical history. She presented to the hospital with frequent clusters of seizures for 1-day duration. There was also a history of the child receiving 3rd dose of pneumococcal vaccine and the 2nd influenza booster, though there was no documented fever associated with the vaccination. The seizure semiology was in form of multiple episodes of seizures consisting of behavioral arrest, cyanosis, and generalized tonic-clonic activity. The child had to be initiated on multiple anti-seizure medications, but the seizures were still persisting, so the child had to be given anesthetic medication. With pentobarbital coma, burst suppression was temporarily achieved, but the seizures still continued, at which point ketogenic diet was also started, a 3:1 ratio, which had to be escalated in 4:1 ratio. At this point, a diagnosis of new onset refractory status epilepticus was made. And due to the presumed immunological factors which are related to NOS, immunomodulation in form of IV methylprednisolone and IVIG was given. Her etiological workup was done, which ruled out infectious, metabolic, and structural causes. A cytokine panel was also done in both serum as well as CSF, which showed elevated interleukin-1, interleukin-2, 4, 8, 10, as well as 13 and 17. The CSF cytokine levels for interleukin-6 and 30 was also elevated. Because of raised cytokine markers, secondary HLH was also suspected and secondary HLH was also done. At this point, a rapid epilepsy gene panel was sent, which revealed a pathogenic PCDH19 variant. So this was the relationship between the immunomodulation, the anti-seizure medication, and the seizure frequency of the child. So for the initial seizures, conventional anti-seizure medications were given. Burst suppression was temporarily achieved with pentobarbital coma, but seizures still continued, at which point immunomodulation and ketogenic diet was tried. Burst suppression was again achieved, but then the seizures still continued. At this point, the cytokine markers were also tested, which was found to be elevated. And due to this, anakinra, which is an interleukin-1 receptor antagonist, was started. Following the initiation of anakinra, there was a drastic reduction in seizures, and at which point there was an attempted weaning of anakinra. But on attempted weaning, the seizures again started reappearing. So anakinra was again restarted. And again, a second Roiler cytokine was done. The second attempted weaning of anakinra was successful, and the seizures had decreased. And subsequently, the cytokine levels had also decreased. This child was also tried on fenfluramine, a drug which is usually given for Dravet syndrome, because of the similarity in the Dravet syndrome, because the seizures of the child were supposedly triggered because of a vaccination. So fenfluramine was also tried for this child. And because of elevated cytokine levels, anakinra was given in the dosage of 5 to 20 mg per kg per day. So this was a cytokine profile which was done on day 29 and 34. Day 29, interleukin 4, 5, and 17 was elevated, which correlates to adaptive immunity. And again, a third time, interleukins were also tested. So this was the anti-seizure medication and the dosages. Clobazam was given for the child at 2 mg per kg per day. Brivaracetam given at 10 mg per kg per day. Phenobarbital at 30 mg per kg per day, and cannabidiol at 10 mg per kg per day. So at 52 days, the child was discharged on 5 anti-seizure medication. That is clobazam, cannabidiol, and fenfluramine was continued in the same dose. Ketogenic diet was continued, and phenobarbital and brivaracetam were being weaned. The child remained seizure-free at 6-month follow-up. The child improved. She was able to take orally pureed feeds, had improved motor strength, also achieved some improvement in developmental milestones, such as sitting up with support, and therapies were also given. So PCDH19 epilepsy is a well-recognized gene for epilepsy. It is located on the chromosome X. The common presentation is epilepsy and developmental delay in a female child. They can present as focal seizures, which are poorly responsive to anti-seizure medication. They can present early, and they show sensitivity to fever. They may also show multiple semiologies like focal seizure, GTCS, toning, atonic, absence, and myoclonic seizures. The severity is variable, and they're classically recognized by a Dravet-like phenotype, which usually presents in girls. At times, it can also present in boys. So vaccination and fever can be triggers for PCDH19 epilepsy. This was the first case report of NOS, which was reported in a previously healthy child in the context of PCDH19 related epilepsy, because it is commonly related with underlying developmental delay. It also shows there could be an immune mediated process or neuroinflammatory mechanism underlying this epilepsy. Tocilizumab was not given because of the anticipated side effect. Few limitations which were reported in this case report was, we don't know whether anakinra reduced the seizure. The reduction was due to the natural cause of NOS. And also they had added other anti-seizure medications which could have contributed to seizure reduction and elimination. The side effect profiles of anti-seizure medication, which is one of the major challenges while treating NOS and FIRES, are also not mentioned. So at this point, I would like to present the international consensus guidelines, which is published in Epilepsy recently. So the initial treatment of NOS is with the conventional anti-seizure medication and anesthetic medication. At 48 hours, the initial diagnostic workup should be completed. If the etiology has been identified, the child can be managed according to the etiology. If there is an incomplete response at the end of 72 hours, immunomodulation can be given, that is IV methylprednisolone or IVIG. If there is still incomplete response, ketogenic diet has to be initiated at the end of 1 week. Second-line immunotherapies like IV rituximab or interleukin-1 receptor antagonist anakinra or interleukin-6 receptor antagonist tocilizumab can also be given. The learning point is that NOS is a possible phenotypic presentation of PCDH19 epilepsy, And genetic causes should also be considered when you're thinking of NOS. There is also a possibility of neuroinflammation in these genetic epilepsy. And monitoring of interleukin profile can be a good way to monitor the treatment response of anakinra. In future, rapid epilepsy gene panel may have a role, especially in treating challenging conditions like NOS, which may help in targeted therapy. Madam?
Yes, there is a question as to how rapid do reports come with rapid epilepsy gene panel? Have they mentioned anything? Like in our place, whenever we send for a gene panel, it takes at least some 3 to 4 weeks for us to get the report. That is mainly because it depends upon the lab which is processing. And if they have many samples and it depends upon the their facility available in the lab, they may give a rapid report or it may get delayed. So for us, it usually takes at least 3 to 4 weeks minimum. In this journal, whether they mentioned how early they get the report?
No, madam, they've not mentioned the turnaround time for the rapid epilepsy gene panel.
Dr. Bishru or Dr. Kaushik, do you have anything to comment on that? How fast can we get the reports on?
Ma'am, actually, I also had the same question because I don't think we have something like a rapid panel at this point of time. Whatever we do is the same as you said, it takes 4 to 6 weeks. So
Yeah.
actually, I wanted to know whether they have mentioned or somewhere like, what, do they include all the genes that actually can present like this? Or is there an abbreviated panel based on the, epidemiology of the disease in that particular area? And then there is a rapid turnover. I don't know, because I don't think in India at this point of time, we have this because all our genetic tests take 4 to 6 weeks, not before that.
Yeah. And second thing is that for this child, this was the first presentation. The child did not have any developmental delay according to them. The child was okay, did not have any vaccine-related induced seizures or anything to suggest that the child had a genetic background. And how they went for looking for this, I don't know. But this is a very interesting observation. And one more thing is that this is, as you mentioned, this PCDH19 is gene. Actually, there is a deficiency of allopregnanolone in these patients, and this endogenous steroid is a potent GABA receptor modulator. And there are studies going on now, phase 3 clinical study to evaluate the efficacy and safety and tolerability of adjunct therapy with ganaxolone, which is an analog to this allopregnanolone. So that is another thing which is recently going on. And as you mentioned, pheno is a better anticonvulsant. Is it? Is that what you got from literature review? Is it? You mentioned something about phenobarbital.
Madam, for this child, the first burst suppression was achieved with pentobarbital coma.
Okay.
In literature, they have given, there are case reports where clobazam has been tried with success. Sodium valproate has been tried with success. Also ketogenic diet. Many drugs which are useful in Dravet syndrome has been tried for this condition because of its similarity. But they've not come up with specific consensus guidelines for the treatment.
I think there are a few more questions.
Should
we go for the next one or we will keep it towards the end?
I think if you can take these questions rapidly, ma'am, so that for continuity's sake, then we can, just discuss this one. So if you can take these questions now, I think there are two
Dr.
questions.
Deepak has mentioned that LifeCell has launched a rapid genetic panel. That is what he has informed. And Dr. Prashant Juari has is asking whether a Sanger confirmation of PCDH19 mutation was performed in this child. In this case report, is there any mention on that?
No, ma'am. Sanger sequencing, they have not mentioned.
Not mentioned. Okay. So these were and Dr. Shiji also has mentioned 2 to 3 weeks time it takes for them to get the panel. So
and Dr. Vijay, I think, has mentioned whether inflammatory markers and genetic workup is routinely recommended in refractory status.
Actually, in refractory status, one thing is most of us, because we have fires like presentation, what we do is we rule out an infection as early as possible. And then the recommendation is that you should start the immunosuppressive therapy with IV methylprednisolone or IVIG or rituximab as early as possible to get a benefit out of this, and then in refractory cases to go for this anakinra and such things.
Yes.
But and of late we know that even autoimmune encephalitis, they can manifest as nose-like presentation. So that panel also will have to do as early as possible. I don't know from this, what we learn is that sometimes there can be a genetic base also, but this is a rare report. This is the first report that has come up. So I don't have an answer to say whether in our a country like ours, whether we have all these facilities to do in every case of nose. This it depends upon the institution and the financial status of the patient in a resource poor country like ours.
So Dr. Saurabh had made a comment that, with extra payment, some labs are doing for ICU and urgent cases, and in the West also the rapid panel turnover is around 2 to 3 weeks. So what exactly Dr. Shiji commented. So I think we can move on to the next case now.
Okay, Shiji,
Okay.
you can go ahead.
So this is the second case report of inflammatory myositis in a child due to an anti-NXP2 antibody. It is the first case report. It is reported from India, and it was published by the NIMHANS team in Neurology India, July 2022. So the case report is of a 10-year-old boy born out of non-consanguineous parentage with, again, no significant antecedent history. He came with complaints of insidious onset, proximal, followed by distal upper and lower limb weakness, followed by painful myalgias, which was progressive in nature for 1 month duration. The child could barely walk with support and would stop due to pain. He required support to rise from the floor and to get up from supine position. He could not raise his arms overhead, indicating proximal myopathy of the upper limbs. It was associated with subcutaneous edema of the lower limbs. He also had dysphagia and nasal twang in his voice after admission. There was a history of his myalgia being exacerbated on exercise. And there was no history suggestive of myoglobinuria, second wind phenomena, muscle cramps, skin rashes, or vasculitic symptoms. This is to rule out the other metabolic causes of myopathy. There was no significant family illness. On examination, the child's systemic and vital parameters were normal. Palatal movements were sluggish. On motor system examination, there was proximal more than distal weakness, that is grade 2/5, and grade 3/5 distal muscles, and the weakness was symmetrical. Tendon reflex was sluggish except for preserved ankle reflex. Sensory and cerebellar system was normal. There was contractures which was present in biceps, hamstrings, and tendoachilles. So coming to the investigation, the significant finding was there was an elevation of the transaminases, that was SDOT and SDPT was elevated. CPK was significantly elevated. In the myositis profile, anti-NXP2 antibody, which is anti-nuclear matrix protein 2, which is a myositis specific antibody, was found to be positive. ANA profile and ANCA, which was to rule out associated autoimmune conditions, were negative. A TMS for acyl carnitine was done, which was negative. Hemogram was also found to be normal. So muscle MRI T2 images were taken, which showed severe hyperintense signals suggestive of inflammation in both the gluteus maximus as well as the median. In bilateral thigh involvement was present, involving both the anterior, the medial, as well as the posterior compartment. And inflammatory changes were present in both legs as well, involving both anterolateral and the posterior compartment. A nail bed capillaroscopy was done, which showed features suggestive of underlying inflammatory myositis, that is microhemorrhages and dilated capillaries. So with a history of progressive symmetrical muscular weakness, severe myalgias, MRA features with a positive myositis profile, elevated transaminases and CPK, the diagnosis was inflammatory myopathy. According to the EULAR and the ASIA criteria, this is a probable juvenile myositis. It is probable because they are not done muscle biopsy. If muscle biopsy had been done, it would have qualified for definitive juvenile myositis. So the child was initiated on IV methylprednisolone intravenous immunoglobulin, and there was significant improvement in myalgia, bulbar weakness. And the child was ambulant by 2 months. He was discharged on monthly pulse methylprednisolone and MMF. At 6 months follow-up, the child is going to school, but elbow contractures were present. So these are the different phenotypes seen in juvenile inflammatory myositis. One is the classical juvenile dermatomyositis, which presents with rash as well as symmetrical weakness. The other one is the juvenile polymyositis, which can present with absence of rash. Cardiac involvement may be present with severe muscle weakness, so that the child may need assistance for ambulation. Echo was not done for this child. The other entity is overlap myositis, which may coexist with other autoimmune condition, with Raynaud phenomena, interstitial lung disease, arthritis, and malarash. A CT thorax and abdomen was done for this child, which was normal. And the other entity is clinical amyopathic GDM, where the skin rash may be present for at least 6 months. There will be no clinical signs of weakness, but there will be laboratory signs of muscle inflammation in form of elevated transaminases, CPK, EMG, or either MARE features suggestive of inflammation. So different myositis antibodies have got classical phenotypic manifestations, and these are the common antibodies which are associated with myositis. In our child, we had anti-NXP2 antibody, which is associated with peripheral edema, distal weakness, severe cramping, dysphagia, calcinosis. It may have some association with malignancy. So in the previous studies which were also done, distal weakness was seen. In our child, it was proximal more than distal. Dysphagia was seen in this child. Child had severe myalgia, severe weakness. Subcutaneous edema was seen in this child, though calcinosis cutis was absent. They may have some risk for malignancy. So tumor screening for different tumors have to be done. The other antibodies which are identified as TIF1, gamma, MD5, PMSCL, MI2, and Jo1 antibody. An Indian study was done with a recent study was done, but no antibodies were identified. So the learning point is myositis antibody profiling in muscle MRI can be used for the diagnosis of inflammatory myopathy. And each myositis specific antibody has got its own unique clinical correlation at times. Early diagnosis and treatment can prevent complication, which can be both systemic and as well as local complications like contractures. It responds well to immunomodulation like methylprednisolone pulse and steroid sparing agents. It is important to look out and rule out other DDs like metabolic myopathy, because in this child, there was a history of myopathy which was worsened by exertion. So in such case, metabolic myopathy must be ruled out, toxic myopathy must be ruled out, and missed and post-COVID myositis can also mimic inflammatory myositis, but it is usually associated with fever. It is more acute in onset and associated with raised inflammatory markers. So that was not there in this child. So that was the second case. Madam?
Okay. That was a nice case, Asmi, because this case, we all think that this inflammatory myopathy, usually they have a proximal muscle weakness, but this child also had a distal weakness as well. That was a very important thing. And again, exertional dyspnea especially, and also myalgia. And calcinosis as well as contractures are also described, and also they can have bulbar palsies, these patients, and rapid course they can have. And they haven't mentioned about the muscle biopsy, but one thing which has been mentioned in the literature is that even if you do a muscle biopsy in these patients, there will be absence of lymphocytic invasion of the muscle fibers in anti-NXP2 positive patients compared to anti-NXP2 negative group of inflammatory myopathy. And it is more like a ischemic damage to the muscle fibers. That is what is mentioned in the biopsy when I check the biopsy in such patients given in the literature. If there are any questions, we'll take it up, and otherwise we'll move on to the case. And one more question was that, was EMG done for this child? Did they mention anything on
They didn't mention EMG, man. EMG can be done for inflammatory myopathy. It is one of the ancillary tests which is being done for inflammatory myopathy.
And Dr. Kalpana has mentioned that anti-SRP positive acute necrotizing myopathy can also be seen in children. Yes, of course, madam, we can see that. But then the classical finding is that the inflammatory infiltrate into the muscles is not seen in such cases, and also that is seen in some of the patients with myopathy. Okay, so we will move on to the last case because we are running short of time.
Okay, madam. So the last case is that of a 15-year-old boy with progressive cerebellar dysfunction. It was accepted in Green Journal of Neurology. It was published by Go et al., was based in Children's Medical Institute, National University Health System in Singapore. So this is a case of a 15-year-old boy who was previously normal, who developed a subacute onset of progressive cerebellar dysfunction over a period of 3 weeks. And his examination showed ataxic gait, unsteady tandem gait, horizontal nystagmus, intention tremor, and ataxia on heel-toe shin testing. Dystidokinesia, dysarthria were also found. Neuroimaging and CSF biochemistry was normal. So this child was diagnosed to have a subacute onset of pancerebellar syndrome. And upon serum as well as CSF autoimmune panel, his metabotropic glutamate receptor type 1 antibodies were found to be positive. His cerebellar function improved remarkably with 3 months of initiating immunotherapy. So this is the video of the child, both pre as well as post treatment. So we can say the broad-based ataxic gait of the child. No other neuroaxis was involved. It was a sole isolated cerebellar involvement. So this is the tandem gait, which is unsteady for this child. This is the horizontal nystagmus. So all the cerebellar signs were found to be positive for this child. And this is intention tremor and dysmetria was also found for the child. And this is post-treatment. This is after immunotherapy was given. The child had remarkably improved, and there is almost nil deficit present at the time of discharge. This tandem walking had also improved. So there was almost complete resolution of all his neurological deficit after giving immunotherapy. So this was another case which was published in Child Neurology Open by Erica Chandler, Nicole Arventis, and Bethany Morgan. This was published in Child Neurology Open. They were based in Division of Child Neurology in Louisville, USA. And this was also another case of idiopathic metabotropic glutamate receptor 1 encephalitis in a pediatric age group. So this was a 5-year-old girl who was developmentally normal with no significant antecedent history. She initially presented with prodromal symptoms like nausea, vomiting, abdominal pain, fever, and headache. Neurological examination was normal. She was discharged with symptomatic medication from the emergency department. The child was again readmitted 3 days later, this time with encephalopathy, unsteadiness of gait, and persistent vomiting. On examination, the child was encephalopathic, responding only to noxious stimuli. Child was afebrile and having tachypnea. There were no meningeal signs of irritation, but due to a presumptive diagnosis of meningoencephalitis, we started on empirical acyclovir, vancomycin, and ceftriaxone. The CSF at that point was not done. And the first CSF was traumatic. EEG showed diffuse slowing of the background. There was no interictal epileptiform abnormality. No ictal discharges were also present. So in the result of serum study, we can see the inflammatory markers were normal. Blood culture was negative. There was some ketonuria, probably because of persistent vomiting. SARS-CoV antibody, ANA, C3, C4, TSH, T4, as well as the serum T and B cell phenotyping for malignant cytology was also normal. An MRI was done for this child, which showed in the axial T2 as well as in the sagittal T2, we can see there is hyperintense lesion both in the cerebellar vermis as well as in the hemispheres medially. And the right is more involved than the left. In the sagittal T2 section also, we can see hyperintensity involving the midline cerebellar hemisphere as well as the vermis. So with the subacute onset of symptoms, EEG showing diffuse slowing and the MRI findings, the diagnosis of autoimmune encephalitis was presumed, started on immunomodulation, but there was suboptimal response with IV methylprednisolone pulse. So IVIG was given at 1 gram per kg for 2 days, with which the child showed remarkable clinical improvement. So by the time the second CSF results had come, and for which the child showed a 1:64 dilution positivity to anti-mGlu-R1 receptor antibody in CSF, there was also some lymphocytic pleocytosis. And at discharge, her neurological examination was also normal. So metabotropic glutamate receptor 1 encephalitis, previously thought to be an autoimmune encephalitis entity involving adult. The median age described for this autoimmune encephalitis is 55 years. It's also now being described in the pediatric age group. So this was the third as well as the fourth case which has been described. A cerebellar syndrome is the commonest phenotype which has been mentioned. The other phenotypes seen are behavioral changes in form of irritability, agitation and mood changes, psychiatric disturbances, cognitive defects in form of memory deficit and spatial disorientation, seizures, dysautonomia, movement disorders like myoclonus, dystonia, choreoathetosis. So mGlu-R receptors, they are a large family of G protein coupled receptor. They are involved in excitatory neurotransmission, both in the peripheral as well as the central nervous system. They have a high concentration in the cerebellum and the limbic system, which explains the predominance of cerebellar symptoms and at times limbic encephalitis in such cases. They have a paraneoplastic association, which have been described in adult population, specifically to lymphoreticular malignancies like Hodgkin lymphoma, cutaneous T-cell lymphoma, ALL, mantle cell non-Hodgkin lymphoma, and prostatic adenocarcinoma. Brain MRI characteristically shows cerebellar hyperintensities and meningeal enhancement. Usually, mGlu-R1 receptor antibodies should be done in both serum as well as CSF. The treatment in adult cohort depends upon the initial MR score. So if it is more than 2, the treatment response may not be very good. They may have some residual sequelae. If it is less than 2, they may have complete resolution. So the learning point is mGlu-R1 receptor encephalitis is seen in children as well. Cerebellar involvement with MRI change is the most common phenotype. One case, which is a predominant movement disorder, has also been described. A child had orofacial and appendicular choreoathetosis. Tumor screening should also be done in children, though no tumor association has been described in children. Autoimmune etiology is more common. Antibodies should be tested in both, preferably in CSF and serum. They have responded well to immunotherapy in children. Madam.
Actually, usually what is the commonest cause for attacks, acute or slightly subacute ataxia that we come across in our hospital? And what made these group of authors think that this is probably a autoimmune process? Because most of the time we also see quite often acute ataxia or subacute ataxia, and we don't go for this autoimmune panel, no, unless we think that it's a MOG related demyelinating disorder or something based on MRI or other things. We don't go for the autoimmune panels. But why this specifically they have looked for this? Was there any particular reason why
they have not mentioned any reason, madam, but one possible reason could be the child had suboptimal response with methylprednisolone. So maybe.
But then they have just used it for 2-3 days only, no? After 3 days, they have started another.
Yes.
Usually it may take some more time, no? So I don't know how we can go on investigating for all autoimmune panel for all acute attacks, yes, whether it's practical in our setup. And another thing which I would like to ask is, what is the other metabotropic receptor, autoantibody against other metabotropic receptor, and what is it called as?
Madam, mGlu-R5 receptor encephalitis thing, which has got
That
a
is
very
again in adult.
associated with Hodgkin lymphoma. It is produces a syndrome known as Ophelia syndrome, and
What is that? Ophelia syndrome.
it produces memory
Who is
disturbances.
Ophelia? Who is Ophelia?
It's named a character in Hamlet.
Okay.
She actually
So there is
suffered from memory disturbances in the play.
Okay. And there was she finally died also, but
Died
this
also.
case of autoimmune encephalitis due to Ophelia syndrome usually responds well to immunotherapy. Okay. So there was one question regarding the previous case report which you mentioned as myositis. Was there any value on AST and ALT? And I remember you mentioning that both were elevated, AST more than ALT, as usually we come across in muscle disease, including Duchenne muscular dystrophy sometimes, not Duchenne, Becker muscular dystrophy sometimes. They just go to the gastroenterologist with a elevated STOT and STPT. Some of them land up getting the liver biopsy also done because people do not check their do not do a neurological examination. So this child also had a elevated AST and ALT values.
Yes, ma'am.
Again, somebody else has also mentioned that metabotropic glutamate receptor 5 related antibody in Hodgkin's lymphoma, Ophelia syndrome, predominant neuropsychiatric manifestation, and mGlu-R3 associated Rasmussen, but the causal relation is not established. Okay. Okay, I think there are no more questions on that. Dr. Vishru, I hand over now to you.
Thank you so much, ma'am. Thank you to both the speakers as well as to Dr. Mini for moderating the session. Indeed, it was a very interesting session because we expected it to be like this only, that we'll be listening to cases, all rare presentations, treatable conditions which will have genetic implications, treatment implications. So I think it was an excellent session, very well presented by both the residents and very well moderated by Dr. Mini. So if anybody has any comment to make, Dr. Kaushik, you want to say something? Kaushik, are you there?
Yes, sir. No, I just wanted to congratulate the residents. They did a wonderful job and wonderful moderation by Dr. Mini. We should thank Dr. Mini for taking such a great initiative and training residents. Thank you.
Thank you, Dr. Kaushik and Dr. Vishru and all the attendees. And also I thank Anju as well as Asmi, who have gone through all the 15 or 16 journals they have screened for all the case reports and prepared from that. They only chose the articles and brought to me. So thanks for them. Good night.
Thank you, ma'am. Thank you. Good night, ma'am. Thank you.
Good night,
Thank you,
everyone.
Vishru, sir. Thank you.
Thank you. Good night, everyone.